Good afternoon, and welcome to our special National Consumers League briefing on federal opportunities to protect the value of copay assistance programs for patients. My name is Milena Berhana, and I am a health policy associate at the National Consumers League, or NCL. Founded in 1899, NCL is the leading national advocacy organization dedicated to protecting and promoting social and economic justice for consumers and workers in the United States and abroad. And you can learn more about our work and programs at nclnet.org. In May of this year, we had the opportunity to hear from advocates and experts about the impact of a CMS patient assistance penalty and how it threatened access to critical copay assistance programs. Today, we are excited to host another advocacy briefing and hear from guest speakers who will provide critical and timely updates on the federal landscape around copay assistance and advocate opportunities to raise your voice in the discussion. Here to moderate today's discussion is Sally Greenberg, the Executive Director of NCL since 2007. Sally is the primary spokesperson for NCL on the issue of copay assistance and has been an unwavering supporter of patients and consumers on the issue. So Sally, take it away.
Why, thank you so much for that nice introduction, Milena. I am so pleased to be here among this panel of dedicated patient advocates. So just to give you a feel for what we're going to do in the next hour, we're going to be hearing from experts about the important role that copay assistance plays to help patients access and adhere to their prescription medications. And more importantly, we'll learn about the ways all of us can raise our voice to protect copay assistance for the communities that we serve. Our panelists will have the opportunity to discuss topics such as federal healthcare rulemaking activities, congressional efforts to prohibit copay accumulators, the 1557 non-discrimination rule, as well as how federal regulators are engaged on issues related to copay assistance. And we're also going to have the opportunity to engage in a discussion with our panelists and take questions from our live audience at the conclusion of today's program. Before we begin our official program, I want to thank our live and on-demand viewers for joining us for today's event and for taking the time to better understand how we can help protect consumer access to affordable treatments. On behalf of NCL, I'd also like to thank our guest speakers for taking time out of their busy schedules to participate in today's event and share their perspectives. Our presenters today include Jim Turk. Jim's a patient advocate with the National MS Society of Wisconsin, Carl Schmidt of the HIV and Hepatitis Policy Institute, and finally, Colette Koulianos of the National Hemophilia Foundation. Before we begin, we want to remind everybody why we're here. In May of this year, we held an advocacy briefing on the issue of copay accumulators because we felt it was important to get engaged or to engage and protect patient assistance programs for our most vulnerable consumers and patients. We know that when patient out-of-pocket costs go up, treatment adherence goes down, and quite dramatically. Increasingly, insurers and pharmacy benefit managers are refusing to count the value of copay assistance toward a patient's deductible or out-of-pocket requirement for the plan year. Many of these patients, especially those with rare or complex diseases where there is no generic alternative to the brand drug, depend on their medications to keep them alive. They cannot afford necessary treatment without copay assistance. Now, consider the effects of inflation and the effects that inflation is having on prices as they rise in just about every category of goods and services: food, housing, healthcare. Copay assistance is a truly vital resource for consumers who are struggling to make ends meet and managing a serious, often life-threatening disease. Right now, there is wide bipartisan agreement across advocacy communities that federal policymakers must take action to require health insurers to count the value of copay assistance toward patients' out-of-pocket costs. So today, we're really going to dig into these issues and explore opportunities to raise your voice to protect vulnerable patients who rely on copay assistance. A friendly reminder for our live audience before we begin: everyone on today's webinar is in listen-only mode, but you can use the chat feature to submit questions to our speakers throughout the program. With that, let's get started. I'm going to start with introductions of our speakers. To begin our program, we have invited Jim Turk. Jim's an advocate who works with the National MS Society of Wisconsin. He's going to start the discussion off. Jim has been an active member of the MS Society since his diagnosis of multiple sclerosis in 2008. Jim has been actively engaged in state-level education efforts on copay assistance issues, including several published op-eds to bring awareness to the issue. In recognition of Jim's invaluable advocacy, he was named the MS Activist of the Year in 2019. Jim, thank you very much for joining us today. The floor is yours.
Thank you very much. I'm going to start out a little bit by talking about maybe I'll tell my story. Maybe I'll start that way. So up until 2008, I was a super active person. Graduate school, I graduated in 2007, have a family, a wife and 2 kids. I was an avid marathon runner, I drummer in a band, right? I my whole life, I pretty much played drums in the band. What else? I was working full time. I mean, you name it, and I was doing it. And I was volunteering a lot for the MS Society, obviously. So it was really quite a shock when I was diagnosed with MS in 2008, and I was losing my abilities pretty fast. So I could no longer run, I could no longer drum, all those things that I thought defined me up until that point. So it was certainly a huge shock. And so, of course, I, like a lot of other people, wanted to get on a drug that was going to stop the progress and make things better for me. At least, at the time, I was really concerned about that, obviously. And something like copay assistance really was able to help me out with that, right? The drug company would pay the money to help me pay for the drug. Otherwise, I wouldn't be able to afford that prescription. But especially now, because I'm on disability, and anybody who's on disability knows that it's hard to live on that, right? And so I needed to have some assistance. Otherwise, I was put in a position where I wouldn't be able to afford my drug anymore. So, and I'm really active in the MS community, as we said earlier, and I've talked to lots and lots of people who depend highly on it. I actually was just talking to somebody who was newly diagnosed on Saturday, and she was telling me how important copay assistance was to her, and to be able to afford her drugs and stuff like that. Basically, the way I look at it is, the drug company offers me, my drug is one of the cheaper drugs for MS, and it costs $70,000 a year. It's a 2-time infusion. For some reason, I was putting my hand in front of the camera there. I shouldn't have. But so if you do the math, it's $35,000 of treatment. Well, if my insurance company, or if the drug company offers $20,000 as their maximum yearly benefit, and my drug company says, okay, well, you have to pay $6,000 out of pocket before we, and that's the maximum amount of pocket that you'll have to pay. If I didn't have assistance, or if the insurance companies didn't count that assistance towards my out-of-pocket maximum, I would be stuck with a bill for $6,000 before I would be able to get another treatment. And so that's just something I couldn't do. Who can afford getting a $6,000 bill in the mail? So it's kind of a surprise, and I wouldn't be able to do that, and I would just stop taking the drug. And I know a lot of other people that would be in the same boat. Like I said, if you're on disability, you're already pretty limited in income. So there's basically no way you could afford that. So it's extremely important that the money that the drug companies provide counts towards that maximum out of pocket. The other thing is, with MS in particular, like I have, symptoms vary so much from person to person, and how much they react to a particular drug. Even the same virtual drug, even if it's a generic versus a name brand, there's slight differences. And that could be enough to cause a problem. So it may be, and often is, a case where you only have one choice. Everything else causes a reaction. You can't handle it. All right. So, maybe you need that copay assistance, even if there is a generic available, because that generic won't help you. Right. So my only option, or an only option for a lot of people, would be to get that copay assistance and not have that count towards your maximum out-of-pocket benefit, so that you can continue taking that life-saving drug, or that drug that prevents you from losing all of your abilities. All right. So that's where I stand on it. I am very passionate about it, obviously, and that's really it for me. So thank you so much. You're on mute, Sally.
Thanks, Jim, for that very compelling story. And patient stories really bring this issue to life, and I think communicate better than any of us advocates possibly can, the choices that you guys are facing and the importance of copay assistance. Next, we're going to hear from Carl Schmidt. Let me introduce Carl. He is the executive director of the HIV and Hepatitis Policy Institute. Carl has been a national policy and advocacy leader in the HIV community for over 20 years. In December 2019, Carl formed the HIV Hepatitis Policy Institute, which promotes quality and affordable healthcare for people living with or at risk of HIV, hepatitis, and other serious and chronic health conditions. Carl has expertise in healthcare financing systems, including Medicaid and Medicare, and has been a champion voice for patients on issues relating to patient affordability, copay assistance, and copay accumulator programs. Carl, thank you so much for being here, and I'll turn things over to you.
Thanks, Sally. And just wanted to confirm that you could all see my slides.
Looks good to me.
Perfect. So I'm just going to provide, and thanks, Jim, for sharing your story as well. So I just wanted to provide a federal update on what is going on in the issue of copay accumulators. So just the outline of my comments, I'm going to talk about why copay assistance is needed. I think Jim did a good job, but I'm going to give some stats. Just introduce the issue of copay accumulators for people who aren't familiar with them, and then what federal actions have been taken to date and what advocates can do now to make sure that copay assistance counts. So I think it's, everyone knows that it's just getting harder and harder. Once you pay for your premiums for your insurance, there's still additional costs, and you have cost sharing and you have deductibles. You have to meet your deductible first. And this is just from federal data looking at the silver level median deductibles, but you can see it's up to over $5,000 a year. And that's an increase of 23% since plan year 18. And I'm sure this year it will go up even more. So that's a lot of money that you have to have before the benefits kick in. And, it's just getting harder and harder. Sally talked about inflation, everything, the price of things are going up, but this is looking at some Federal Reserve data. And this is not like a survey. This is looking at real data in 2019. And the people who analyzed this data said about a third of a single person household with private insurance in 2019 could not pay a $2,000 bill, and half couldn't pay a $6,000 bill. But as you heard from Jim, his out-of-pocket costs, were like $6,000. And they said with an average of out-of-pocket maximum for a single coverage of over $4,000 in 2021, the study concludes most households do not have enough liquid assets to meet the typical out-of-pocket maximum. Well, this was done looking at 2019, and we know the world has drastically changed in the last couple of years. Prices have gone up for so many things, And I just saw this yesterday, a survey it came out. It said almost 1 in 5 Americans, 18%, have skipped a medical appointment or filling in prescription drug in the last 6 months because of a financial strain. So, and as Sally mentioned, when people don't have the money to pay the out-of-pocket costs, they just abandon their medications. They don't take it. And this is kind of hard to believe, but in 2021, 81 million prescriptions were not picked up. That were prescribed, by their provider for an issue, a health issue that a patient has. And you can see as the copay cost sharing goes up, the abandonment rate goes up. But, even looking at between $50 and $75, 26% of these are brand name drugs. The people did not pick up their drugs. That can't be good for the health of these individuals. And it's not good for society as well. So as Jim said, the drug companies offer copay assistance. And if you look at 2021, total out-of-pocket costs for prescription drugs was $63 billion. That's the money that all of us have to come up with to pay for the out-of-pocket costs for prescription drugs to pick them up. And manufacturer assistance was $12 billion. So, you can see the value of that in helping so many millions of people around the country. But what has happened in the last couple of years, as you've heard, is that more insurers and PBMs are saying, we're going to take that money, that $12 billion from the drug manufacturers, but we're not going to count it towards your deductible and maximum out-of-pocket spending limits. So this is from the AIDS Institute, and this is a little detailed. I'm not going to go into it, but this is showing 2 scenarios of a patient and the drug company and the insurer, and how they are affected, first without a copay accumulator program, and then secondly with a copay accumulator program. But what I think the takeaways are, when copay assistance counts, you could see the total in this patient scenario, the copay assistance was $7,200 that the manufacturer pays, the consumer pays around $1,350, and the insurer collects $8,550. Now, looking at the second scenario, when the copay assistance does not count, the bottom line is this: copay assistance from the drug manufacturer was the same, $7,200. But look at the patient now. They are now because first the copay assistance was counting, and then they have to pick up their drug, and they learn that it didn't count. So they are then on the hook to pay for that money, and that they have to come up in this scenario $8,000. So this is, the damaging, hurtful impacts on patients. We already talked about that. People don't have. Yes.
Your slides are not advancing on the screen. They're still stuck on the on slide 1.
Oh no. Maybe someone else could advance them.
Yes, maybe stop sharing your screen for a second.
Okay. Oh, I wish you'd have spoke up earlier.
Yes, sorry about that. We'll see if we can share. Okay, we're going to see if we can get your slides up and just move them.
But what you were saying was very interesting, Carl.
I could continue speaking, but
let's give it a minute and see if we can pull the slides up. There we go.
Well, sorry, you didn't see these great graphics. So yeah, I was on this slide, and you can see that the insurer collects, not only does the patient pay a lot more money, but the insurer collects a lot more money as well. Next slide. So, we already talked about this is damaging for patients, and this is growing. Again, from the AIDS Institute, they looked at marketplace plans, and they found that 35 states have at least one plan with a copay accumulator. 8 states, every plan has a copay accumulator. They say here that 3 states in DC have no copay accumulator programs, but I could tell you that my plan in DC, unbeknownst to me, to just a couple of weeks ago, I saw they now have a copay accumulator plan here in DC. So things are getting worse. And next slide. And the Kaiser Family Foundation, of their analysis of the employer plans, they found that around a quarter of them, if you have 1,000 workers or more, now have instituted copay accumulator programs. So this is just, taking off more and more and in hurting patients. Next slide. So what can we do? We have been going to the federal government and asking them to say copay assistance must count. And every year, this is since the Affordable Care Act started, the federal government puts out a notice of benefit and payment parameters rule. And this is what the plans have to live by. These are the parameters of, what's the total out-of-pocket maximum cost? What are some other, things that you have to do? Network adequacy, our formularies. So we have asked them to say that copay assistance must count. And so we started many years ago, and when it says 2020, that's the 2020 rule. And they're always doing this almost like 2 years in advance of when it actually goes in effect. So it gets a little confusing. So in 2020, we actually successfully had the Trump administration say that in their rule that copay assistance must count. It was in most situations. They could be limited when there's a brand name drug when a generic exists. Unfortunately, before that rule went into effect for the 2020 plans, they suspended it in August of 2019. And they gave this reason, some IRS health savings account, reason having to do with drug discounts, which has nothing to do with copay assistance. So we were really disappointed, and we tried the next year for 2021. And unfortunately, they said that copay assistance did not have to count, and the plans could decide themselves if they want to allow copay assistance to count or not. They did say that states can decide if copay assistance counts, and it's been great. And we're talking about federal activities today, but 14 states have now said copay assistance must count, but that does not impact all plans. It's only the state regulated plans, not the larger employer plans. So we need a federal solution. And in 2022, despite the advocacy efforts by many, there was no mention of this issue at all. So that means the 2021 rule still stands. And then 2023, there were several iterations of the Notice of Benefit Payment Parameters Rule. First, it was under the Trump administration, then it was redone under the Biden administration. And again, advocates pushed and to say that copay assistance must count. Unfortunately, in both the Biden and the Trump administration, there was absolutely no mention, even though the communities were so active in asking them to do it. So now we're at 2020, we're now working on, right now it's September 2022, but they are now going to put out in the next couple of weeks a proposed rule for the notice of benefit and payment parameters rule for 2024. So we have an opportunity to influence that right now, and I'll talk a little more about that later. Next slide. So there's also a bill in the Congress, and it is HR 5801, and it's bipartisan. It's been introduced by Don McEachin. He's a Democrat from Florida, and Rodney Davis, who is a Republican from Illinois. And I looked this morning, it has a total of 60 sponsors in the House. And this says that copay assistance must count. And so this is another avenue of where our federal advocacy can work. And I'm sure Colette will talk about more about this as well. But we know it takes time for Congress to enact legislation, but we have an avenue with the notice of benefit and payment parameters rule at the Department of HHS. We have Congress involved. And next slide. And another part of our federal government is the judiciary. And so my organization, the HIV and Hepatitis Policy Institute, along with the Diabetes Leadership Coalition and the Diabetes Patient Advocacy Coalition, recently filed an Administrative Procedures Act complaint against the Department of Health and Human Services, against the 2021 Notice of Benefit and Payment Parameter Rule. That's the rule that said that copay assistance did not have to count. And we filed this in DC District Court. And we are going after two issues. One, ACA violations, legal, against the law, and then some things that it's arbitrary and capricious. So first of all, on the ACA violations, we say that insurers are collecting more than the legal amount of money that they should be collecting. And as I showed in the patient scenario, that they're collecting more money. Also, the ACA definition of cost sharing says any other expenditure required of an insured individual. And then there's also regulations that define cost sharing as any expenditure required by or on behalf of an enrollee. So those are the ACA claims that we're after. Next slide. We also are saying that it's arbitrary and capricious in what the government did. In that rule, it says they allow the insurers to decide if copay assistance can count or not. And also they say that 2019, we say that the 2000 rule was abandoned without explanation and failed to present options. So we're requesting that they set aside the 2021 rule allowing copay assistance and that declare that copay accumulators are illegal. Next slide. So just to wrap up, current federal advocacy actions. There's also a proposed rule on health care discrimination, which is Section 1557 of the Affordable Care Act. And that says you cannot discriminate based on someone's sex, race, age, disability, health status. So, we think copay accumulators are discriminated against people with chronic conditions. It's only people who have chronic conditions and who have serious conditions that rely on prescription drugs. So we are encouraging people to submit comments. They're due October 3rd. We have a patient group sign-on letter. We would encourage people to sign on to it. There's a link here. But also send in your own letters to the Office of Civil Rights at the Department of Health and Human Services. Also, the Notice of Benefit and Payment Parameters rule. We encourage people to weigh in now with both HHS, the White House, use patient stories, use the media. And I think the arguments that we laid out in our legal case are good to make as well, that this violates the ACA. And then talk about the current economic hardships and the inflation, what's going on with people these days. And then seek sponsorships for the congressional legislation. So I think that's all I have. And sorry, the slides were not advancing, but look forward to any discussion and hearing Colette's comments as well. I'm sure she'll amplify some of the things that I talked about.
Thanks a lot, Carl. I just wanted to, Donald McKeechan's from Virginia, Richmond, Virginia.
Yeah.
Glad we have a bipartisan bill. And you mentioned lawsuits against HHS. Have there been lawsuits brought against the insurers as well?
No, you know, this is the way to get to the insurers, I guess. So if we had to file suit against every insurer, every PBM that's doing this, that would be a lot of work and a lot of money. And I think this is the way to do it, is to go after the rule that allows it.
Mm-hmm. Okay.
But we can talk about that, Sally.
Yeah, that's, I just wanted a little clarity. So that's in federal district court in the District of Columbia.
Yeah, it was just filed.
It's just filed. Okay.
Yeah.
And you filed it with HIV/AIDS Institute, filed it with, what was the diabetes group?
2 diabetes groups.
Okay.
Yeah.
Okay. So, and that's been done, and people who are interested in joining the suit, is that
Oh yeah,
option?
we would love for patient groups to join in with us. And there'll be opportunities for amicus briefs as well. We're still waiting, that we made some accusations against the government. They have an opportunity to respond. It will be really interesting how they respond and say, comment on what we've said.
Okay, great. Thanks for clarifying that. I'm going to move now to an introduction of Colette Koulianos. Lastly, she's our last speaker. Colette is the Senior Director of Payer Relations with the National Hemophilia Foundation, NHF. As the Senior Director of Payer Relations for NHF, Colette is responsible for the development and execution of NHF's payer education strategies and programs. Colette and her colleagues at NHF are critical steering committee members in the All Copays Count Coalition. And this is an alliance that's composed of members serving the interest of beneficiaries with chronic and serious health conditions that rely on copay assistance to access medically necessary treatments. Colette and NHF have conducted invaluable research on the impacts of copay accumulator adjustment programs, research that is the backbone for much of the policy that we do. So Colette, the floor is yours, and thank you so much for being with us.
Thank you very much for the introduction. And I will tell you that since you had that title, I am now the Vice President of Payer Relations. And I only say that in case somebody on this call heard me speak recently and thinks, wait, did she just get demoted? Okay. All seriousness, I've been with NHF almost 7 years and been addressing this issue almost the same amount of time. We saw the first copay accumulator that you heard Carl go into great detail about on a plan in late 2016 that was to be implemented in 2017. And as you guys know, these have gone off the rails. We know the data, Avalir data tells us 83% of commercial enrollees are on a plan that has a copay accumulator. I did want to address too the data you shared from the AIDS Institute, which I think is such compelling data. They're specifically looking at marketplace plans. So if they say a state doesn't have an accumulator, it doesn't mean you don't have one on an ERISA plan or a self-funded employer plan. They're simply looking at the marketplace plan. But so I just want to, I'm going to step 1 second back and then I will dive head first. Health plans, so all the healthcare purchasers, that would be your big health plans like Blue Cross Blue Shield, United, Aetna, Anthem, et cetera, and self-funded companies. So companies who self-fund their own insurance for their employees. They all have said for several years now that high-cost claims are a strategic priority. That means that specialty medications, which is the highest cost drugs, is part of their target. And so what do? They go to their tool belt and they start to use the tools they have available to them to try to address these high costs, because that's their job. And so their strategies include, some of the biggest ones, patient cost shifting. So we're seeing more and more high deductible health plans. And as Carl mentioned, the deductibles are ever increasing, patient cost shifting, annual out-of-pocket limits. Next year in 2023 is $9,100 for one person, $18,200 for a family. I mean, that's egregious if you think about the income, the average median household income. It is, you can't make the math compute. And they do other strategies as well, but we're seeing more and more of these pushing the cost, pushing the burden onto the patient. The idea is if we push the cost to the patient, they'll be better healthcare consumers. They'll choose a name brand instead of a generic. Those are some of the arguments they use for why copay accumulators are good. But they also talk about what you heard Carl mention, the IRS HSA issue, which I will just dive into briefly. But Carl gave even more recent data as far as what the average deductibles are, which are up over $5,000. So I think his data is better. But the bottom line here is the continued burden that's being placed on American people. So I'm not going to go through the accumulator policy, what it means. He did a good job on that. I just want to make sure I point out that copay accumulator policies, these copay adjustments, you could find them on any health plan, a marketplace plan, a small group, large group, or an ERISA or a self-funded plan. And so because they don't go against the ACA, so they could be on any plan. So that's important. Adhere says that 83% of commercial enrollees have an accumulator on their plan. And so I'm not going to go through this slide because Carl did a good job talking about how accumulators work, but this kind of goes through the process of where it impacts the patient and to that point where they'll abandon their prescription. And for most chronic disease patients, abandonment's not really an option. It's a short-term Band-Aid. What ends up happening is the plan may see short-term savings because patients are no longer getting their meds, so it looks like they're winning. But really, it's pushing patients to the higher cost of care setting, which is the hospital emergency room to get an infusion. And data tells us it can be up to 10 times higher cost to the plan. They know that, so they don't realize some of these strategies are backfiring or will in the end. Let's talk about the IRS HSA argument, because this is a big one that's really been popping up a lot from both state and in federal conversations with legislators, because the reason that the NBPP that you heard Carl talk about, NBPP 2020 said no accumulators if there was no generic, but then they walked it back. So it was issued the final rule in April of 2019, and it was to go into effect January 2020. In August, they walked it back because they said people were contending that would be a violation of the IRS HSA rule. And so CMS said, we are going to look into this and we'll address this in 2021. When they came out with the 2021 rule, as Carl said, it said you can have an accumulator if you want one. Well, to me, that was an answer. It didn't violate any IRS HSA rule, but it truly is not an answer because what they're actually talking about with this challenge was in 2004, informal guidance in the FAQs, question number 9, the question was asked, can an enrollee who is on a high deductible health plan paired with an HSA contribute to the HSA if he uses a discount card or a coupon? Now, I'm going to get into in a minute why it's important to stop saying discount cards or coupons when we're talking about accumulators, because they aren't discount cards and they're not coupons. The money we're talking about is assistance. And there is a difference. A discount card or coupon, if I take $1 discount or a coupon to the grocery store, I get $1 off my bread. The grocery store collects that $1 less. Now they get it from the back end. But if I help somebody standing in line in front of me and say, he's short money, and instead of making him put groceries back, I offer to cover the shortage, and he profusely thanks me and he goes to walk out the store, the reality of what an accumulator is that somebody stops him at the door and says, get back to the register. And he says, no, that lady paid the difference. And he said, doesn't matter, you have to pay it yourself. That's essentially what they're saying with an accumulator. So it isn't a discount card, it isn't a coupon. But even if we pretend that, okay, let's call it that for this moment. The actual answer that the IRS gave was that yes, they could contribute to the HSA if they chose to, but they would first need to meet the minimum deductible. Now, the minimum deductible to become IRS, by IRS definition, to become a high deductible health plan is $1,400. But as you heard Carl say, their deductibles and out-of-pockets the average is over 5,000, but they can be all the way up to the annual max out of pocket, which is 8,700 this year. It'll be 9,100 coming up in January. So the patient doesn't have to pay that whole 8,700 or 9,100. They only have to meet the 1,400 in order to be able to contribute to their HSA. And then they could use the assistance for the remaining. But that's not what these insurance companies are doing. They're applying it across the whole balance. So I do want to go again. What's a discount card? GoodRx is a discount card. An Optum discount card. Those are discount cards. We're talking about assistance, and it's important to clarify. But since the IRS 2004 guidance, actually, they didn't address what cost sharing means, but the ACA, after that 2004 guidance, did address it. And they said that it's any expenditure required by or on behalf of an enrollee to respect their benefits. So any amount paid by or on behalf of the enrollee counts to their cost sharing. That was set in the ACA, and yet that's not what they're following with these rules. So now we're going to go into the maximizer programs. And these are different from an accumulator in that you heard me say that a copay accumulator can be on any plan, whether it's a marketplace plan, small group, large group, ERISA plan, because it doesn't violate the ACA. It's simply a policy change that says a patient can use assistance, but it can no longer count to his or her out of pocket. But a maximizer actually says, whoops, my battery's running low, folks, let me try before we go dead. The maximizer program actually says that the benefit is a covered non-essential health benefit. So it changes the definition of an essential health benefit, and therefore you will not see a copay maximizer program on a marketplace plan or a small group plan, but you will see them in ERISA or self-funded plans or large group plans. Now, data tells us, Advocacy data tells us 73% of all commercial plans, so that would be ERISA plans or large group plans, have a copay maximizer language in them. So it's proliferating is here as well. Now, in the early days when these two programs rolled out, the copay accumulator or the copay maximizer, I used to say, if somebody put a gun to my head and told me you have to choose one, what would it be? And I always answered, I would definitely say the maximizer is better, because at least with the maximizer, unlike an accumulator, with the maximizer, the patient still gets their medicine every month. So this is how it works. With an accumulator, if the patient I'm just going to make it real simple, $5,000 is his med cost every month. He has assistance from the manufacturer in the amount of $10,000 a year. And let's say his out-of-pocket max is $5,000. That's his deductible and out-of-pocket max. So month one, he goes to get his med with an accumulator. They take $5,000 from the manufacturer assistance. They dispense the med to the patient. After that, they reset the member's accumulator, which is his or her out-of-pocket expenditure, to nothing because he didn't pay anything. So next month, it shows he still owes the $5,000 deductible. Next month, they use the remaining $5,000 off the manufacturer assistance. Now it's exhausted. There's no more assistance available. He gets his med. Come March, the member hits what we call a cliff. There's no more assistance available. He has to either pay the $5,000 deductible, because remember, if there's a deductible, you must pay the entire thing before the plan kicks the first penny in. So he'll be either owe that $5,000 then, or he doesn't get his meds. That's an accumulator. A maximizer takes the value of the manufacturer assistance and spreads it out over the year so that they change the copay amount for that drug to match what the assistance is. And they set the copay different. So they take a select number of drugs, it's usually between 13, 15 therapeutic classes they're targeting, and they remove them outside of the plan because remember, they're calling it a non-essential health benefit. So it's covered non-essential health benefit. They remove it outside the plan. That way they can change the copay amount on those and they can exceed the max out-of-pocket limit by doing that. And so if the member chooses, wants to get their drug, they're told, you must apply for the manufacturer copay assistance program in order to get the drug at no cost to you. Now that's funny because the same argument they use for the accumulator is that patients have no skin in the game and that these assistance dollars help drive drug prices and make them bad healthcare consumers. But on the maximizer side, by the way, same companies under a different name, they make the patient apply for the assistance. And if the patient were to refuse and say, I don't want the assistance, that patient would be responsible to pay the equivalent of that manufacturer assistance. So they would pay whatever that copay was set. If the assistance is $15,000 for the year, that means $1,250 every month the patient pays, and that does not apply to their deductible or out-of-pocket cost sharing. They have to pay the $1,250 a month to get their meds, and they still have to pay their deductible and out-of-pocket for all the rest of their healthcare expenses. So I will no longer say that I would choose a maximizer for this very reason, because it is actually saying specialty medications are not an essential health benefit. But we know that prescription drugs are an essential health benefit. And someone has taken the liberty to say specialty medications are not part of that prescription drug benefit. I mean, specialty medications require a prescription and they're dispensed from a pharmacy. They're a prescription drug. So we've gone to HHS and CMS and said, tell us how this changed. We know a self-funded plan actually can change the definition of an EHB, but only by authorization of HHS. And HHS assures us that they didn't give them that authority. There's only been one such definition change. It has nothing to do with this. And so that's kind of the EHB loophole we talk about. And how these work is they take the drugs that are all the covered healthcare expenses fall within the normal plan. So if using my example, if the patient had a $5,000 deductible and that's their out-of-pocket, all their other expenses go under that. The covered but non-EHB, there's no cost sharing limits, and that sits outside of that typical plan document. So you heard Carl mention HR 5801. That's been growing in support. And I also went and counted this morning, which was funny. It has 60 bipartisan sponsors. It is heavily Democratic in support, but we do have Republican sponsors. This was introduced by McEachin and Davis, McEachin from Virginia and Davis from Illinois. Unfortunately, Davis being a Republican, and he lost his seat. So we do have other Republicans who've stepped forward and said that they were willing to take the lead. So you'll be hearing more about that, I hope. But what we're trying to do today is get additional support on the House side, but also get a companion bill introduced in Senate. We have several Democratic. Oh, sorry.
Thanks, Colette. No, I want to, that excellent, really clear presentation. Love the examples. We've got a couple of questions in the chat I wanted to make sure we addressed. For both, for all three of our speakers. So the first is that if it's true that insurers are collecting more than the legal amount under the ACA, and the second is it goes against the definition of cost sharing. Is that correct?
Yes.
Yes, that is correct.
Yeah, I think the question was on the legal complaint.
Yes, exactly.
Yeah.
Oh, I'm sorry. No,
Yeah.
Carl, I don't know. That's
yes, that is true. And hopefully you'll get the slides, and there's a copy, there's a link to the complaint as well. But it's also the regulations that define cost sharing on our behalf of the enrollee, but also that there's another part of the complaint, and that has to do with it being the rulemaking was arbitrary and capricious, that they let the insurers decide what the definition of cost sharing is. We need a strict definition, and we don't need the insurers and the PBMs to decide what the definition of cost sharing is. And then also that they pulled the rule, they didn't enforce it, and that was arbitrary and capricious too. As Colette said, that IRS issue only affects some people, and even people who have it, there's ways to deal with it, and they didn't deal with all the different options. And so it's not only ACA violations, but that the rule was put forth in an arbitrary and capricious manner.
Yeah, and thanks for the explanation, or the difference between accumulators and versus maximizers. That was really helpful. I'm going to throw out a couple of questions. We don't have much time remaining, but we've got a really very robust conversation going here. We've got some great questions in the chat. A question for our panelists: has CMS or the Biden administration expressed a willingness to engage in a dialogue with patient and provider groups about the topics discussed today?
Well, from our vantage point, we have had, we have never been turned down to have conversations with CMS or CSIO. They've been more than willing to have conversations, but in the end, as Carl has mentioned, they haven't actually acted on it. We hoped that we would gain traction and get attention of the Biden administration early on. There was a bipartisan letter with over 70 signatures on it. It didn't have traction. So, we do have NBPP 2024 sign-on letter that is circulating now. It's open until next Tuesday. We hope you'll sign on. We're hoping that we can get traction. Maybe the lawsuit draws attention, makes them act. Maybe it brought it to Biden's attention, I hope. But that's
is this an HHS issue? Is it a CMS issue, or is it all of the above?
I think it's HHS is the one who comes out with the rules. That's under CMS. I do want to also point out, and I had on my next slide about the All Copays Count website. It launched today. I'm very excited to share. It's been a long time in the making, and it's allcopayscount.org. And there's a lot of resources on there, as well as there's state level activity where you can see which states have bills that are pending, which have passed. You can see the actual language. So hopefully you will all take a look at that.
Okay, a couple more questions I want to throw out there for our audience. Advocates getting engaged in the process. Is there a sign-on letter opportunities, sign-on either to the agencies, opportunity to join the lawsuit, and ways to discuss the issue of copay assistance with members of Congress? We know that there's a bill. People can reach out to members of Congress. Is there a sign-on letter in support of the McEachin? And I assume that you all are looking for a Republican co-sponsor who's going to be a member of Congress, serving member of Congress in the coming, in the new Congress?
Correct.
Yeah.
We do have one who's already stepped forward that we're working through. But yes, and we do have a sign-on letter that is circulating now for the NBPP to CMS. We have had sign-on letters to get Congress engaged. I'm certain there'll be more of those that are coming, but specifically the current sign-on letter is to address the NBPP 2024 and try to get them to correct this issue in that rule.
A couple other questions. Have there been ongoing dialogues with the health plans on these issues?
Oh yeah, there's been dialogue with a lot of we get engaged with self-funded business coalitions and have been serving in that capacity over the last few years, just making sure we're here, getting the voice out there to all the employers, telling them about the unintended consequences. We've had some success in them backing off of these, but there's so many, as Carl said, there's if you talk to every company that's self-funded, we could never get them all. We do our best to try to get this information out, but also working with broker consultants as well.
Okay, very interesting. Employers, so you're having those conversations with employers. That's important. Yeah, this is great information. So we've talked about the best way for advocates to communicate the patient impact of copay accumulators, current opportunities. We've talked about the sign-on letters. We want to make sure people have the tools if they want to speak out. NCL's dinner is coming up in 2 weeks, October 6th, and one of our honorees is HHS Secretary Becerra. So we will continue to have ongoing dialogues with the powers that be in various agencies. And I think we've covered most of what we want to talk about. Let's see where we are. We're 1 minute before we're set to adjourn. Anybody have anything else we want to say in the remaining 60 seconds that we haven't covered? And I should say thank you all so much for incredibly compelling presentations. All three of you have been just great.
Yeah, thank you, Sally. And I do echo something that Colette said. Hopefully the litigation, we want to be successful, but also I think it raised a lot of important points and that advocates could use, and that hopefully we got HHS's and the administration's attention, and that in the next notice of benefit and payment parameters rule, with all of your help, they will say that copay assistance must count.
Okay, well, I think that is a wrap. On behalf of the National Consumers League, I want to thank our esteemed guest speakers and all of you who attended today. We hope you found today's program valuable and encourage you to get involved with the National Consumers League on this issue and all of our advocates who are who are on the call. And we've got lots of stuff in the lots of links in the chat. I think they'll be helpful. So thanks everybody, and we could bring the meeting to a close.